right. Well, it's 7 o'clock, so let's go ahead and get started. Um, I'm going to do just a really quick introduction and really a welcome to everybody who's attending from home or watching this in the future on BCHU. We have a multidisciplinary grand rounds today on the subject of how to optimize our patients in primary care when they are entering the operating room. There's been a few, I think, wonderful developments in terms of protocols, and they have uh, several items today to answer all of those most common questions and the most stressful part of clearing patients for surgery. So thank you to putting this together and that team approach. And I will pass it to Amy.
Hi, everyone. I'm Amy Meditz with infectious diseases, and also with us today is Dr. Susie Hagen, general surgery, and Dr. Owen Ellis, anesthesiologist extraordinaire. So Susie's going to be running the slides, so pardon my prompting her occasionally. So what we're going to do is first, we had some goals that we set out for this grand rounds, and that's in the email, and I'm not going to reread those, and I'm just going to go straight to our case. Next slide. So this is a real case that we embellished a bit. So it's a 71-year-old male. He has an activity level of 3 METs, history of a stroke, coronary artery disease, CHF. He's got a pacemaker, an AICD, and the AICD is there because he has a low EF. He has atrial fibrillation, diabetes, obstructive sleep apnea, and he's getting a major surgery, a TLIF at L2, L3, L3, L4 in about a month. He also has a history of a superficial soft tissue infection following a CABG 1 year ago, and the cultures showed C. acnes. Also, it's noted that he has a penicillin allergy, but nothing is really listed as far as the details regarding that allergy. He has a very limited activity. He cannot climb stairs at baseline. He has an elevated BMI, and he's on some pertinent meds that are highlighted here, including furosemide, an SGLT2 inhibitor, a GLP-1 inhibitor, and Eliquis. Next slide. So this is the part that I am going to focus on, the fact that he had a history of infection, and then we're going to talk about unclarified allergies. Next slide. So prevention of postoperative infections is very complex. Obviously, there's the big component, and this is really what Dr. Hagen and Dr. Ellis are going to focus on, is and how you really can also help is what's the patient's general health, stability, and the management of these high-risk medications around the time of surgery. This really plays an important role in post-op infections. Also, I'm here to talk about that we have to place more emphasis on the preparation of the skin prior to surgery, as well as bowel prep, which I'm not going to address today. There is a lot of processes that happen in the operating room. This is all protocolized, and we're going to review a little bit of this today just to help everybody understand what's going on, and so you can help build your patient's expectations of what's going to happen. Finally, post-operative care and wound care and resources. This is where our team as infectious diseases sees things go wrong sometimes. People don't realize how much care is going to take after this surgery, and a lot of things go wrong at this point. So that's something that you can help your patients prepare for. So everybody here is well aware that surgical site infections increase morbidity, mortality, and healthcare costs. Just looking at these pictures is shocking. These are some examples of post-operative infections I've taken care of, listed, and I've numbered these. So in number 1, this is a gentleman who underwent a total knee arthroplasty, went to a skilled nursing facility, fell 3 times and dehisced his wound and got a post-op infection. In the second, there's a slice of a CT scan with the helpful arrow showing the mediastinal abscess. This is an individual who had end-stage renal disease on dialysis. All of that was brand new. He needed emergent open heart surgery. And his course was complicated by this post-operative infection. In number 3, this is a person who had an obstruction of their right colon due to a malignancy, had to have emergency surgery, had a post-op infection of an abscess in their abdominal wall. And finally, this fourth picture is a cervical laminectomy. This person had weakness in their left arm and needed a semi-urgent laminectomy to relieve that problem. What I'm trying to show you with showing you that slide is, although I'm going to talk about the ways that we reduce post-operative infections today, we can't control every variable. We cannot get this to zero, but it doesn't mean we should give up. We should always be trying to reduce the rate of our post-operative infections. So how can we do that? So first, what I want to tell you today, may be surprising, it may not. This is something infectious diseases doctors have been telling patients for a really long time, is that most SSIs are caused by a patient's own microbiome. How did we know this? Well, this was just an observation of skin flora being a common cause of post-operative infection. But this recent study in 2024 in Science Translational Medicine did a wonderful, eloquent job of showing how this really is the case. So what they did is they took patients and they swabbed at various places in their body preoperatively. Then they did a spinal surgery on them and they followed them prospectively. And in the individuals who developed a post-operative infection, they took that bacteria, which matched exactly the bacteria that they had previously. This really stresses the importance of preoperative microbiome management. Next slide. What do I mean by that? So we have a bunch of strategies that help us manage the microbiome. What I mean by that is reducing the amount of bacteria on the skin. And there's a variety of ways in which we do this. So I want to direct your attention to the right side of the slide first, these green boxes. So what I'm going to start talking about is kind of what happens when the patient first hits BCH and they're in the pre-op area. They're going to get a skin prep in the preoperative area, and they're going to get a nasal decolonizer. This is standardized and will be recorded in the electronic medical record. And so the nurse does this part. Then they go to the OR, and that happens again with a similar product to CHG. In addition, patients are going to get perioperative antibiotics. These match with what we are expecting as possible post-operative infection, and this is based on the type of surgery that they're getting. This is in order sets, and it helps providers know what the dosing is also. Some of the doses change depending on patient's BMI. If you're interested in knowing more about this, these are in our antimicrobial stewardship book, and you can look at what are the expected bacteria as well as what the perioperative antibiotics are. So going back to the left side of the slide and the blue boxes. So as I mentioned, our patient had a prior post-operative infection. So they may benefit from seeing infectious diseases prior to their surgery to help either emphasize the skin prep prior to getting to BCH, or they could have had an unusual bacteria and we may need to consider adjustment of the perioperative antibiotic. So this is a good part of trying to prepare the patient. So next slide. I'm going to go into more detail about this antiseptic skin preparation and what I wanted to say about that is that CHG has been compared directly to iodine and has been shown to be superior CHG has been shown to be superior to iodine. Excuse me. So what we have recently done is build resources to help providers to support compliance of preparing their skin prior to surgery. Before I go into more details about what this is all available on our website, bch.org/skin prep. Also, of course, we'd be happy to email it to anybody. We have these QR codes I don't know whether they would work during this talk. So why do we do this? You are probably not going to be the ones ordering this, but we think that it's so important that primary care support this idea, know what's going on, because these patients trust you. And having that, reinforcement from the primary care team is very important. In addition, you may be well aware, it takes people 3 or more times to really understand things. I mean, how many times have we heard patients that they didn't hear about that? So this is an effort to try to come at them from all different directions. This is on the left is the handout, and this goes through the procedure, which starts 3 days before surgery, and it's giving people instructions on how to shower. Believe it or not, people need that. They're not getting in between into the crevices of their body. Also, it's important to leave Hibiclens on the skin 2 to 3 minutes, but no more. In addition, we have a bunch of FAQs for people who might have questions. Finally, we have a video. It's 3 minutes long. I welcome you to watch it. I am taking a shower and showing people what they need to do in preparation for surgery. Next slide. All right, on to the next topic. As I mentioned, the patient had an unclarified penicillin allergy. Inaccurate and incomplete documentation of drug allergies and ADRs does cause harm. And on the left, I have the bigger problem. That's why it's weighting down on this scale. Patients, we put things in the chart without these clarifications that lead to patients getting less effective, more costly medicines that may have a greater risk of adverse events and therefore increase their length of stay. On the other side, this is what everybody's scared of, is that we don't put a medicine in and somebody has a life-threatening reaction. This is a very unusual scenario, but it's what we're all worried about, and it's driving the additional of putting everything into this allergy list, despite it not being a serious reaction. Next slide. So this is a snap of a patient's very long allergy list. And to orient you, I didn't do the best of job of snapping this, but the second column is the snapshot description. And you can see there's a whole long list of unknowns towards the bottom of this list. It doesn't tell anything, doesn't tell the provider anything. Doesn't say whether it's a true allergy or a non-serious side effect of this medicine. And it creates a bazillion alerts. We all have clicked through them and we totally ignore them. And it may delay the most effective medicine, receipt of that most effective medicine. So how do we combat this? Next slide. So, sorry, skipped a slide. I just wanted to give you a little bit more information about allergies. So, sorry, go back to that slide, sorry. So, patients often report allergies to beta-lactams and opioids, but it's not accurate. So, penicillin is by far and away the most common allergy reported in the United States. And this statistic just blows me away. And this is proven time and time again that less than 1% actually have a true allergy. This is just a remarkable statistic. In addition, regarding opioids, at BCH, 60% of our opioid alerts come from opioid listed in the allergies, and 44%, almost half of them, don't have any clarification. Next slide. So this, what I want to say is that you're lucky today. I'm lucky too. We're not going to have an immunology lesson today. So I'm not going to go over how to truly differentiate between various reactions to medications. Instead, we're going to gather the most important information so that we can make good decisions. So this left list of questions is also in the antimicrobial stewardship book. And this is getting this information is going to help make sure your patients get the best perioperative antibiotics or other therapies regarding narcotics for surgery. It's, the typical way we ask people questions. We start broad and we get more details. How long ago did the reaction take place? Did you need medical treatment? Why was the medication being used? The example I like for this is if you were giving somebody penicillin for syphilis, they may have the Jeris-Herxheimer reaction afterwards. And people could easily say, oh, I had a reaction to penicillin, but in fact, they were just having a febrile episode after treatment for syphilis. On your right is another snap of the electronic medical record. This is in the allergy tab. So what I want to highlight here is the reaction. Sometimes you just don't know how to classify this. So what we've done is try to help you with this. So there's an other under reaction. So next slide. Then you can type .allergy other. So, and you can find this, it's freely available to everybody, and you can star this, and it prompts you to gather the information that will help clarify an allergy. Next slide. This is an example of one I literally did 1 week ago. So when I saw this patient, they had a cephalosporin, the whole class is just listed, just as you see it there. I didn't modify this at all. So what I did is I went through the series of questions, and I readily admit people don't remember what antibiotic they have. So what I typically do is just start rattling off the list of antibiotics. And since Keflex is given 9 out of 10 times, it's a good place to start. And it happens to be what this individual was allergic to. She had a rash. And here you can see I gathered all the information in that dot phrase that I showed you in the last slide. The other thing I sometimes add is patients have a lot of preferences. And this patient really felt that they did not want to be challenged again, even in my hands of whether I thought it was safe or not. I mean, I often add that because that can be helpful. So what does this mean? Next slide. You might think, oh, they're allergic to Keflex. It's a first generation cephalosporin. They would be allergic to cefazolin, which is the most common antibiotic used in surgery perioperatively. Well, that in fact is not the case. Because the beta-lactam cross-reactivity is not a class effect nor a cephalosporin generation effect. It has to do with the side chains. None of us can memorize this. Well, maybe some people can. I personally can't. And this chart helps you sort out if somebody has an allergy to one cephalosporin, are they allergic to something else in this class? You can see that cefazolin, interestingly, does not share a side chain with any other beta-lactam. So it has no cross-reactivity. This doesn't mean that you can just give it across the board. If somebody had a serious reaction to cephalosporin or a cephalosporin other than cefazolin, let's just say cefadroxil, like Stevens-Johnson syndrome, TEN, don't give the cephalosporin. That person needs an infectious diseases or immunology consult to figure out what the best antibiotic is. You can see this can be referenced also in our antimicrobial stewardship book. Next slide. So these are some examples of low risk reactions. These can be removed from the allergies or clarified within the comments section like I just showed you. I want to highlight a couple things. Family history of penicillin allergy is not a thing. That can be removed. Reassure people. Also, many times people even deny an allergy that might be listed. That can be removed. Fatigue is not an allergy. That can be removed. Next slide. Quickly, the next slide shows some examples of significant reactions. This is not usually confusing to people. You should add these in real time. If you have pictures, consider even referencing the date of your note so people can look at the pictures. For example, we recently had somebody who had erythema multiforme to cefazolin, and I added that to the chart immediately so that that can be referenced in the future. I'm going to hand it off now next to Dr. Hagen. Thank you very much.
All right. Well, thank you all for joining us either bright and early this morning, or if you're watching this later, we're so happy that you're wanting to learn more about this information. I'm going to quickly tell you about the NPO guidelines, and then I'll pass it over to Dr. Ellis and then come back and tell you more about the anti-coag protocol. So we used to say historically, just don't have anything after midnight. And some of that was out of convenience. for we're not really sure when surgery will be, so we better be safe than sorry. And what we have learned is that's actually not great patient care. It's not great patient care because they're really hangry by the time it's time for surgery if they're late in the afternoon. And also, it can be a detriment to their surgery as well. So our goals are based off of the American Society of Anesthesiologists. And the biggest point is we want to minimize risk of aspiration. Nobody wants to have aspiration pneumonia. Nobody wants to die from an elective surgery. So we need to optimize in this area. This is the most general considerations, and there are exceptions. So exceptions would be an emergency surgery. We say, hey, the risk of aspiration is smaller than delaying the surgery. We have special populations, for instance, pediatrics, or what about those teeny tiny babies? They don't fall into these categories at all either. The American Society of Anesthesiologists, actually, their guideline is no food or solid things or anything with protein or fat for 8 hours prior to surgery. And then no liquids, clear liquids, we'll go into that, for 2 hours prior to surgery. But sometimes the operating room runs ahead of schedule. So at our institution, we have said your last meal or anything with protein or fat, and not last meal in like a funny sense that that's going to be the last time they ever eat, is 9 hours prior to surgery. And for clear liquids, 3 hours prior to surgery. So let's pretend that their surgery's at 3 in the afternoon. If they wake up early, they can have whatever they want as long as they're done by 6 a.m. Then from 6 a.m. to noon, we recommend that they have 8 ounces of something with sugar and electrolytes until about noon. And examples of that, Gatorade, sports drinks. I always say, think of hummingbird food. If it has water, sugar in it, that's great. The things we want to stay away from are some of these rich Boulder bone broths that have fat and protein in it, or things that they make at home that we can't verify ingredients in it. And I always tell my patients, please, please do not put cream in your coffee. That will cause a delay in surgery and can sometimes even cancel it on there until we get to these guidelines. So at noon, nothing by mouth. So we're going to review that. So the patient at 3 o'clock, they can have breakfast as long as they're done by 6 o'clock, have Gatorade or something else like that until noon, and then afternoon, nothing by mouth. Okay, Dr. Ellis, I'm going to let you go through things, and then I'm going to show you all on Epic at the end where to access some of these protocols.
Unmute.
There we go. All right, let's try that again. Good morning, or later in the day if you're watching this not real time. I'm going to go through some things about the preoperative process that we have at BCH. In addition to being an anesthesiologist, I'm a perioperative services medical director and the medical director for our pre-surgery. Used to be pre-surgery testing, now it's pre-anesthesia testing because of all of the places like MRI where patients now seem to be unable to have a study without general anesthesia. And the reason part of the reason we're doing this is because we're hoping that some of the PCPs are going to be able to help us when we have complex patients and the nursing staff that's in PAT isn't really able to collect all the data and help make sure that the patients are optimized. And so some of the things I'm going to go through are not really, I'm going to go over pretty quickly because we're not really expecting you to do the entire lab testing workup for a surgical patient, but rather help us with the complex things and also be able to answer questions about what the patients may ask. Why am I having this? Why am I having that? And so we've highlighted some of the things that I'm going to go through here. You know, the activity level, the diabetes, the OSA, plus we'll talk about the strokes and the coronary artery disease, and then some highlighted medications that are confusing, probably less to you than the surgeons, but it's still confusing. So we're going to help with management of anticoagulation and recommendations. Dr. Hagen is going to come back to that, understanding what we do and how we do it. And then we're going to ask you to, if you have feedback, you can email me or Susie, and we can get we'd like to improve it if you see things that don't make sense, because most of our testing is based on medications or medical conditions as opposed to what surgery is coming up. So the basic process, we have nurses who specialize in this. They will call the patient, and we have a lot of algorithms for how to manage diabetes, how to manage pacemakers, how to manage ICDs, what the procedure is, the medical testing. That then gets transferred in Epic to one of the 6 anesthesiologists who reviews patient charts, where the labs will actually get ordered, when we will ask for additional documentation or testing as indicated. And then that will get followed up as needed until it finishes. But that's the piece where we're hoping you may be able to help us sometimes when it's so complex and we have patients who are from out of state and they really need somebody who has a physician who has time to really look at everything that's happening. So looking at this patient, we got a lot of problems, right? We have to make sure that they're 1 year past their coronary artery bypass. Is that still stable? What are we doing with their pacemaker? We use electrocautery during surgery. So if you're using electrocautery too close to a pacemaker and ICD, that's obviously bad. Obstructive sleep apnea is a significant postoperative risk factor. AFib is always a problem, previous strokes. And then they're on a bunch of medications, diabetic medications, diuretics. Are they anemic? It's a big surgery. Are we going to do a type and screen? Things like that. And then we still have to deal with the fact that they're anticoagulated. So this is the brief overview. We use a very sort of, it's not really a red line, but it's a pretty rough line. If they're greater than or equal to 4 METs of activity, that pretty much limits what we do, except we sometimes have to evaluate conditions without recent follow-up. For example, if you have somebody who says, I have aortic stenosis. 5 years ago, they told me I had it, I should watch it. I'm still hiking, I'm doing really well, but I haven't had an echo for 5 years. Then we're going to go ahead and probably want an echo to just make sure that it hasn't progressed and they're well compensated. And then I just mentioned the Duke Activity Status Index. There's a link to it. It's kind of nice. It's more comprehensive. It has an online calculator that whoever's talking to the patient just fills out. It's the same idea. It's just a little more accurate. So we'll probably change to that. And then there's an algorithm. I am going to send this to Alyssa so that you can all see it. You don't have to memorize it or use it, but at least you'll know what it is and what we're kind of looking at. But I didn't put it here because it's actually about 2 pages long and somewhat complex. But in general, we test mostly based on patient history and patient factors. So what drugs are they on? Are they in end-stage renal disease? Do they have chronic renal insufficiency? Things are mostly based on patient medical conditions. We don't do very many procedures. We don't do very much testing based on the surgical procedure, except for larger procedures. We definitely are going to screen for anemia because that's an independent risk factor for bad outcomes. And why do we get basic metabolic panels? It's for diuretics, end-stage renal disease, diabetes. Some anti-seizure medicines mess with it. So it's complex, but mostly based on things. And occasionally there's surgical needs. For example, if you're having a parathyroidectomy, we're going to get a PTH as a baseline screen. We rarely get EKGs unless you are under 4 METs. That will trigger us to get a screening EKG, or if you already have existing EKG concerns, as this patient has a fib. We never get chest x-rays as a screening exam. They're not useful, and we would get them only if somebody said, I have a really bad cough and chest pain, and then we would get a chest x-ray and send them back to all of you anyhow, because we don't know what to do with that. And then things like echoes and stress, all health status-based things, and rarely do we get those except for high-risk patients. So that's just an overview of what we do. So let's talk about what some of the special cases. So diabetes, we actually have a protocol for it. The protocol is for people who don't have pumps. People who have pumps and or continuous glucose monitors, we ask them to bring those, and we will actually run the continuous glucose monitor. We can look at the continuous infusion. If they have it, we can look at it real time. We can watch it during surgery, so it's pretty useful. But if not, there's a protocol about 2/3 of your Lantus the night before and half your regular in the morning, things like that. But now we've got new medications, and they're not always for diabetes, but there's two classes that really trip us up. One is the GLP-1s, which are the, very famous weight loss drugs that are out there. And the way they work for weight loss is, and probably diabetes to a certain extent as well, is they make you delay gastric emptying. So your stomach doesn't just feel full, it is full. And obviously, based on the previous NPO discussion, a full stomach right before surgery is a bad idea. So they came out, the history is they came out and nobody really thought much about it. And the anesthesiologist started writing letters to the editor saying, wait a minute, this patient was on a GLP-1 and I put them to sleep and yesterday's lunch reappeared. Because when you get anesthesia, you relax all of the sphincters, like the lower esophageal sphincter. And so they came out and said, all right, well, we're going to hold these medications. If it's a once weekly dose, you're going to hold it for 7 days. If you take it daily, then you hold it for 24 hours. And that's for the current state. It turns out that even 7-day holds aren't all that effective, and lots of people still have a full stomach. So probably in the near future, we're going to be switching that to don't hold the medication, but you can only have clear liquids for 24 hours prior to surgery, which can be a little bit of a shock for the patients, I'm afraid. The actual guidelines under there evaluate for risk, how much gastroparesis do they have, and some people only need to be NPO for 8 hours and some 24, but that gets sort of a little too complex to try to install in a system. So it's probably going to be just clear liquids for 24 hours for those drugs. The other ones, and most people don't really know about this, and the surgeons, particularly the orthopedists, I don't mean to run them down, but they don't pay attention to this, really can't distinguish between these two classes of drugs. So that's where you can also help. The SGLT2s have a very significant risk, which actually has an FDA black box warning on it about euglycemic ketoacidosis with stress from surgery and fasting. So these need to be held 72 hours or more to avoid that. And this actually does lead to significant numbers of surgical delays when patients don't get this information in advance. So if you see patients on this, you can help them remember not to take it 3 days before surgery. That would be helpful. And this is a group of people that we highly encourage to have something like Gatorade 3 hours before surgery, because the problem here is that the SGLT2s make you excrete glucose, and so you get into a ketoacidotic state because you don't have enough glucose. Quickly, for a recent MI, that's within the last 3 months. Generally, they already have a cardiologist, and if they don't, we're going to get them one, but they should. So how long do we wait? So if they had an MI, the cardiologist looks at a small MI, we didn't stent them, they're just going to need medical management, then it's less than 6 weeks, incredibly high risk to extend that MI and have very bad outcomes. 6 weeks to 3 months is intermediate risk. That's where we might balance the risk of the surgery versus the risk of not doing the surgery, which can also have significant consequences. And over 3 months, that has sort of returned, it's returned to baseline risk, whatever the patient had before. Stents are a little different. It depends on what the stents are, whether they're bare metal or what the drug in them is. I just put that there. That's not something we usually have to deal with. If a cardiologist put in stents, we usually involve the cardiologist to tell us when they can stop their dual antiplatelet therapy. So I mentioned that just because we've had people come in at like 6 weeks saying, okay, everybody told me I'm good to go. And it really isn't quite that. And then for strokes and TIAs, the data is pretty clear from Europe that if you have an elective surgery within 9 months of a documented stroke, you have a higher increased risk. You have a increased risk of extending that stroke or having another stroke in the perioperative period, which is bad. It's a little confusing in the US because somebody did a US study and found that it's only 3 months. But when looking at the data, the general consensus was, well, that's because Americans in general are less healthy than Europeans. And so the baseline they can return to is sort of higher than what the European data suggests. And so at this time, we're looking at the European data saying, well, maybe what we really need to tell patients is, hey, you got to wait 9 months, and you might be well advised to actually clean up your lifestyle in those other 6 months to decrease this risk, because the American data shows that in the US, the risk of stroke does not go down, of restroking with the perioperative period doesn't go down to the same level that it does in Europe. So we're just at higher risk across the board. And then TIAs, we don't have a lot of data. 3 months is probably okay for a mild TIA. If it was a big one and maybe it was a stroke, maybe not, it's hard to say, then we probably might wait 9 months. And so that's where we get a lot of people coming from neurologists saying, hey, you can go at 3 months, and we're like, well, maybe not. Obstructive sleep apnea, this is another big one. This all came up because patients would go home after surgery, and then the anesthesia and the opiates gave you even more decreased respiratory drive. Many patients have very bad outcomes on postoperative night 1 at home with untreated sleep apnea. So if they're untreated, we're going to tell them to get treatment. If that's not possible, we'll move them from an outpatient surgery center to the hospital so that if they don't look really good in the recovery room, we can admit them. And if they are treated, they need to have been treated for at least 6 weeks, because that's how long the brain chemoreceptors take to reset, and then we don't do much else. Pacers and ICDs, just know they're there. We'll deal with those. We'll call the reps and figure out how we're going to manage it, because it's a little complex based on where the surgery is, where the box is, what it does, are they dependent, things like that. And then the other thing is a lot of people have deep brain stimulators, spinal cord stimulators, and things like that. If you can help us remind the patient, hey, bring your controller, because we'll just turn it off at the beginning of surgery and turn it back on at the end, and that sort of obviates that risk. So those are the big focuses that might help you.
Well, thank you, Dr. Meditz and Dr. Ellis. I always learn a lot and helps me review on that. So I am going to focus on the anticoagulation protocol. Bear with me just a moment while we switch over to Epic, because I want to show you, of course it timed out, where to find these protocols on here. So when you go to your Epic, I'm going to pick a day where don't have that. We want to go to more. And then from more, we're going to go to reference links. This is an amazing tab for all of you. Up to date is on here. And then the antibiotic guidebook and the gram is on there. And I actually, even as a surgeon, reference that because it is so smart, and I'm so embarrassed all the times I have to call my ID colleagues, and that helps me. But towards the bottom here, we have this peri-op anti-coag algorithm. And from here, I'm going to expand this a bit. And this probably took us about 3 years to actually make, and really appreciate pharmacy and anesthesia really pulling together for this. So on here, one of the things we do is we look at, first of all, what is the bleeding risk? If it is a very small bleeding risk, for instance, doing a skin biopsy, there's several surgeries that are listed under that. We want them to continue their anticoagulation. We do not need to interrupt it and create that risk for the patient. If they have had an issue such as a PE or DVT during the last 3 months, then we need to sit there and say, okay, do we need to delay surgery? If we can't, then we need to figure out ways to work around that. Then from here, we figure out, are they on warfarin or one of the other ones? And then it gets very confusing because we're like, do you need neuroaxial anesthesia? And for those who are not in this world, that could be a block to numb a leg so they have less narcotics after surgery, or an epidural. And so a lot of our guidelines are based on if they would have a potential of needing that neuroaxial anesthesia. And the reason why we're keeping this in Epic is it's a living document and things are happening with here. So then we can come down and figure out which of the drugs we're on and how often to hold it. So for instance, in our clinical case, if it's a low bleeding risk, we can hold it for 48 hours. If it's a high bleeding risk, it's 72 hours. This is really neat because it also talks about bridging on there. And then we go through and we'll have our antiplatelets available. And then here's additional information on here. What about for cataracts? What about for dental surgery? What about for a pacemaker or all these other things or endovascular? And so we have that included as well. The final page is on the neuroaxial anesthesia on there. I am going to stop sharing. I don't think it went back on there. That's the, did it go back to the PowerPoint?
No.
Not yet.
No.
Okay, hang on there. While I figure that out, I'll have the, there we go. Back to it. This is where to find that again. And this will also have the MPO guidelines. This has, if you forget the skin prep thing, you can all figure this out from just the BCH website on there. I think one of the most important things I want to leave you all with, or we want to, is help surgeons help the patients. If you have concerns, speak up. This is a really longitudinal relationship that you have with the patients, and it is so deeply appreciated. And I sometimes have people come to my office who didn't even tell you all what their concern was. And if someone is not thinking carefully about the patient as a whole person and thinking about just the whole, HOLE, in the patient, or the HOLE we want to create in the patient to fix something, that may not be the best thing for a patient. For instance, if you see that they have been declining over years and they all of a sudden come and see a neurosurgeon and say, my back pain has been acting up, and they see something that could be the cause of that back pain, and they want to schedule them for a 5-level back surgery, and you know that is only going to decline the patient's overall well-being, we really need you to speak up. This happens more often where surgeons can get very focused on the procedure they want to perform and it really not be for the benefit. And then they sometimes get referred back to primary care for, quote, clearance. But if you have concerns, speak up. And again, you could, if you don't want to go directly to the surgeon, talk to Dr. Ellis or myself, and we're happy to help with that, because I think that's really, really important that we're working together for this. And I think that's one of the beautiful things about being in our institution is Boulder Community Health is not a community hospital in that it's lesser, but we are a community. We are a team of physicians, advanced practice professionals that work together to care for the patients at the absolute highest level. And that's what's beautiful is we have each other's cell phones, we have our Epic secure chat, and we're able to voice those concerns without concern about that. And then Owen, this is back to you. He's still muted. Anyhow, his daughter gives him this, and I tell Owen that I often find coffee mugs that I think I should get him.
Yeah, so this is what my daughter thinks of me. She gave me this a couple of years ago for my birthday, and I didn't have any other fancy pictures or algorithm or flowcharts to put up. So I put this here just so we can all have a little laugh and answer questions. And I saw a question in the chat. We'll get back to that in just a second. I want to stress what Susie said. We're going to be putting a little bit of a push. Ben Kiden and I are going to be working on getting you all more involved in whether the patient should actually be having surgery, because we have concerns that we see certain numbers of patients come through scheduled for a surgery for a condition that probably possibly warrant surgery. Patient condition just doesn't warrant surgery necessarily, and we're uncomfortable a little bit as anesthesiologists because surgeons saying it needs to be done. The patient wants it to be done because this hurts or that hurts, and they haven't talked to the primary care doctor about, like, is this really good for the patient in totality, as opposed to, yeah, it's going to fix their knee pain. So we're hoping to have you more involved, and as Susie said, by all means, reach out to us if you have any questions, because we're more than happy to intervene and involve the conversation with the surgeon and say, hey, look, we're not sure this is the right thing for this patient.
And
All right.
on the horizon, we are getting a team together of primary care physicians that are going to learn more about the peri-op visits and be a resource for short term. This is not to divert patients from their main primary care, but people who are willing to learn a little bit more of a focus on this and can get them in a little bit quicker. So when we identify those needs, it's complex because Owen may be in the operating room when he's trying to hear back from a cardiologist or things like that. And we want to have people that are from BMC as well as the BCH primary care to help with that. So from there, we're going to go to the chat and answer some questions. So if people that are here have additional questions, please put them in the chat. That's the easiest way. This question is, what do we do about a patient who's non-ambulatory and then they have, need total hip, total knee, and we're trying to figure out, what is their tolerance? And they're like, well, I can't walk because my knee hurts. It prevents me. Oh, and how do we handle something like that?
So you have to kind of back up and think about, why are we looking at a METS level? And the reason we're looking at a METS level is because we want to know if the patient stresses their cardiovascular system in their daily life in the same way that we're going to stress it with surgery. So if they say, I was great, 3 months ago I was hiking Long's Peak, and now my knee's so bad I can barely get out of a chair, that's fine. We're going to consider that greater than 4 METs because that was in the last 3 months. If somebody said, I've got knee pain, I haven't been able to do anything for the last 2 years because my knee hurts, we're going to consider that less than 4 METs because we don't know, they're not stressing their cardiovascular system enough for us to know where it is. And we're doing this, not, the dividing line is American College of Cardiology and some other studies have said if they can reliably do 4 or greater METs, the stress of surgery doesn't really exceed that, and so you don't need a lot of workup. If you can't document that they can do greater than or equal to 4 METs in the last 3 to 6 months, then you have to assume they can't and make sure we're not missing underlying coronary artery disease or something else. If they're 40 and healthy, and we may get a screening EKG, if they're 70 with diabetes and chronic renal insufficiency, we're probably going to send them to a cardiologist to get a stress test, or you all can order a stress test just to see, because what we don't want to miss is underlying coronary artery disease or other cardiovascular problems that they simply aren't manifesting because they can no longer exercise.
So and I'm old, kind of like you. And I remember when I was at the VA, we would often ask, hey, if it wasn't for your knee, could you walk up 1 flight of stairs? Could you walk up 2 flight of stairs? Does that even happen anymore? Is that legitimate? Can we use that for guidance?
That's the question that sort of I addressed at the beginning. If 3 months ago you could do it fine, like 3 months ago your cardiovascular system was fine, obviously, because you could go up 2 flights of stairs without stopping 3 months ago. Now your knee limits you. That's great. The problem is, my knee hurts. I haven't been able to go up 2 flights of stairs for 3 years, and but I'm sure if my knee didn't hurt, I could now. But we don't really know that. Right? There's no way to know that. And so to be safe, we want to make sure that they can. And so that's going to be a stress test or some other thing if they have a lot of risk factors. Because how can you predictably say I haven't gone up 3 flights of stairs and 2 flights of stairs in 3 years because my knee hurts, but I know I can. I don't know how you can know that.
I agree. That's why I asked the question on there. I don't see any other questions in the chat box. Alyssa, you always come up with something.
Dr. Hagan, I wanted, if you could you move the slide back to the one with the skin prep? I wanted to make one more epic point. There you go. So if everybody can see at the bottom left-hand corner, There's these two things. It says BCH infection prevention, skin prep, and skin prep FAQ. So in your wrap up, where you're giving patients instructions, there's an instructions little search bar, and you can search skin prep there and pull in both of these flyers to your patients' post-op instructions easily. So it's these exact flyers. The patients will be able to see it in their My BCH. So I wanted to make sure everybody was aware of that easy way of pulling in this information for patients. We also keep a couple physical flyers in our office because we have some older patients who just prefer pieces of paper.
We do too. I just also want to point out that's one bottle for all 4 showers. I get that question a lot. I don't typically use that volume when I bathe. Maybe I don't know how to bathe correctly, but it's one bottle for 4 showers on there. Okay, it looks like we have another question. Known alcoholic patient and they're not being honest. How do we contact anesthesia to be like, hey, we're worried about this person? Owen, what's the best way?
I just put my email address in the chat.
Okay, you're out of town. Anything else? I know you're actually always available, to be honest, because I've called you on the golf course. But
yeah,
is that the best way, or do you want that to go to PST? Is it really you?
You know, I probably should go to PAT. The problem is I need to identify. I don't have that email address right now, and because it could be Abby, but then Abby might be out of town and expectedly. So I'm not, and this is not to any way negative. Expectedly, the nurses from PAT are somewhat less responsive to their email when they're out of town than I am, because that's just the nature of what that job is expected to be. So for now, email me. When we get it, there should be soon like a email to everybody at PAT that they can all see. The other way that works pretty well is if you have a patient, if you have the patient open an Epic, just start an Epic chat that includes me, and I will add in the appropriate people at PAT to that chat, and then everybody can see it. So that would be the other way, because if you, I never turn off my chat really. So if you chat me, I'll see it. I can see it on my phone wherever I am. I can add Abby or whoever I know is in that office, and we can go from there.
Okay, so for any occult concerns that are secretive, you can either email Owen, O-Ellis at bch.org, or send him a chat and he'll figure it out from there. Okay, we got another question. When surgeons send patients to cardiology for pre-op, they're saying, can you do a bit of a screening? Like if you know they can't do 4 mets and have 18 comorbidities, it really makes cardiology like kind of the bad guy for delaying surgery on there. So, and it's more of a comment of like, if people have a lot and you're just saying a lot going on and you're just saying, hey, cardiology, can you clear them for surgery? And they're like, are you joking me? Like, you know, you have 18 other things going on. Just be thoughtful about that. And it's a team approach on there. And also those are often urgent visits that could be taken away from someone else. So be thoughtful about that.
Right. So there's 2 parts to that. And there's 2 questions there actually. The other one is, what would you like us to start the workup? So first off, a lot of times the surgeon sends a patient to cardiologist before we know about them. So unfortunately, a lot of times I can't screen that patient because they booked the case for 8 weeks from now, and and a lot of times the surgeons won't even put it on the OR schedule because they're worried they're going to get delayed. So they'll send them to cardiology first. We don't know about that. So we can't screen those. The ones that come later are the ones, unfortunately, that get added late to the schedule, or we call the patient doesn't call us back, and by the time we get it, we find out that the patient is not really optimized for surgery. And yes, in a certain sense, cardiology seems like the bad person there, but at the same time, we're the ones telling the patient, hey, you have this condition. We don't think it's appropriate for you to have surgery now until you get this evaluation. We'll do our best to help you get it done, but unfortunately, the surgeon didn't send them. So I can't always screen them because a lot of times I don't know about them. The surgeons just send them without talking to us. And as far as what we'd like the PCPs to do, I mean, I think I trust your to a certain extent, I trust your evaluation. Definitely, if they're less than 4 mets or you have concerns, get a screening EKG. Definitely, if you have a concern, send us an Epic chat so we can look at it early, because that might allow us to involve the surgeons early and say, hey, we just got a thing saying we got this patient that we're concerned about. And the surgeon's already scheduling them, and then we can intervene. And I have for obvious reasons, more of a relationship with a lot of the surgeons than the PCPs do, because I'm in an operating room for multiple hours every day. And so I can reach out to them pretty easily and say, hey, you just put a patient on the schedule that we think might not be appropriate. The PCP is concerned, you might want to think about pushing them back while we work them up.
So take home message is use our resources as a community. Secure chat, ask cardiology if there's anything else they could do to prepare for the appointment. If you have outliers, I recently reached out to Owen because I was concerned and he helped me. Okay, we're going to end on this question. This is Dr. Meditz. They have distant MRSA. Is primary care supposed to decolonize, or do we have them do a swab? And how do we address that? Or is this another thing where they can just call you at midnight and say, Dr. Meditz, what do I need to do?
Yeah, thanks for that question, Dr. Davies. I really wanted to emphasize this when I gave my talk, but of course my brain washed over this. So first, the skin prep is decolonizing everybody. So what we have decided to do over the years, we used to screen people for MRSA and decide what they go to the OR, but now we decolonize people across the board, not only for MRSA, for all bacteria. We're trying to reduce the bacterial load. A history of MRSA is pertinent, though, to document, because it could change what perioperative antibiotics that we use, which we're currently in the process of switching from vancomycin to daptomycin, so it's somewhat heterogeneous, but we would use that coverage, particularly in cases in which skin flora is the primary risk for post-op infection. So it would be helpful for choosing the perioperative antibiotic, but we do not need to screen people anymore because we're universally decolonizing people. Thank you for that question.
All right, Alyssa, anything else? We have about 1 minute left.
I think I will highlight something that Dr. Davis just put in the chat too, which is it's two-way communication. I've definitely been surprised that my patient had surgery, and I would always love to hear about it ahead of time. We tend to take a lot of personal ownership of our people and usually know who they are without even opening their chart to some degree. So yeah, I think it's worth mentioning with anesthesia and all the surgeons that you speak with. Feel free to reach out to us if you have questions as well. So I look forward to greater collaboration and choosing candidates and getting them optimized. Thank you.
Well, from
This
all
was
of us,
really,
thanks.
really helpful. Very excellent pieces, all questions that I've had recently. So thank you.
Good. Well, from all of us, thanks for this opportunity too that we had to share this with you. And I think we have really learned communication is key for the success of the patient. Thank you.
Thank you all. All right.